Hey, Margie here. Today we're focusing on osteoporosis medication. This is a topic I've been asked by so many people to have on the podcast because there's so much confusion. People want to know the answers to these questions. Number one, is osteoporosis medication safe? Number two, when would be the appropriate time to use it? Number three, what's the difference between all the medications out there? And number four, can an osteoporosis medication be part of an integrative, comprehensive approach to our bone health? Well, today you'll get the answers to these questions, and our special guest is Dr. Keith McCormick. Dr. McCormick is a chiropractic physician specializing in the management of patients with osteoporosis. He is the author of The Whole Body Approach to Osteoporosis and his recently released book, Great Bones, Taking Control of Osteoporosis. Sports have always played a vital part in Dr. McCormick's life. He's the former U.S. record holder for most points scored in a pentathlon competition. Dr. McCormick continues to compete in triathlons of all distances and, ready for this, has completed 6 Ironman competitions, 5 of them after recovering from multiple osteoporosis-related fractures. So he's truly a role model. Plus, he is just full of so much information. So stay tuned to this interview. Welcome, Dr. McCormick. I am so happy to be here with you on the podcast. And thank you so much for coming.
Thank you for inviting me, Mark.
First of all, before we get started, I just want to tell everybody, so for my upcoming summit, More Natural Approaches to Osteoporosis and Bone Health, I interviewed Dr. McCormick on how we evaluate. And it was such a phenomenal interview. So you absolutely have to hear that. But we were also started to talk about medications. And I said, this is a topic that I get so many questions because people are so confused. And and there are times where it can really be helpful. And people really, unfortunately, the medical community doesn't really explain the pros, the cons, how it can be used with other things. And so there's really nobody better than you to discuss this topic. So I'm just so happy that you're here today. And we're really going to delve into this and answer questions. But before I start, I have to give you such a big shout out. Your new book, Dr. McCormick has a new book that's just coming out, Great Bones. And it is just a great book. I can't even imagine how much work went into this because I loved your first book. But this is like the encyclopedia to answer all your questions. From everything, from the medications to all the testing to what values you need to look at. So it's something, if you have a question, you just go to this book. It's that good. And I just really thank you for putting all the work in and giving everyone this resource. I think it's going to change the trajectory of osteoporosis. It's just that good. So, and we'll tell everyone though how they can get this book.
For the next week or so, from my website, www.mccormickdc.com. And then hopefully by early March, it'll be on Amazon.
Okay. So that's so exciting. Dr. McCormick sent me the book beforehand, so I've been able to go through it. And it's really just amazing. Each chapter has resources and references, and it's not as though any statement is said without backup information. And it's
1,200 references. So.
And how many years did this take you to do?
2.5 years.
Yeah, it's just, I'm just so excited that it's getting out to the world. And as I said, I'm going to use it all the time. I love the fact that if I have a question, I'm not sure about a lab value, I just go to the book and there's my answer. So thank you for doing this. And, and for everybody listening, this is really something that can just be a resource for you. It's not something you're going to sit and read at the beach. It's not that type of reading, but it's something that's there. It answers your questions and really puts things into perspective. So thank you so much for doing that. Okay, so the topic at hand today is medication. Because for many people, they're like, never, never, never. I'm not going any of those osteoporosis medications. They're so dangerous. There's so many side effects and anything else I can do. And the problem with that is that there are times, there are people, then a person gets a fracture And so there are times that they can be very helpful, but we really need to understand the pros and cons. So let's start with that. Let's start with why should or shouldn't someone consider a medication? Let's just start with that question.
You're right, Marcia. The information out there on the internet is scary because it talks about osteonecrosis of the jaw, atypical femur fractures, all kinds of problems with these drugs. And so I can see why people get really afraid and they call me up and they say, Dr. McCormick, I'm never going to take these drugs. I just want to do it naturally. I want to improve my bone density and decrease my fracture risk naturally. And they have a really poor bone density and they're really high risk for fracture. And I think, when they go to as you said, the medical community, their doctor, whoever, their medical doctor, that person really doesn't know a lot about nutrition and other ways to attack osteoporosis. All they know are drugs. And so I don't feel like they have a really good balanced a view of medications. That's because that's all they really have. So I don't think they're able to say truly the pros and cons. It's all just, hey, this is the way it is. Take this or leave it. And I do feel like I have a really nice view of both sides. These drugs are not bad. They're just bad in the way they're used sometimes. And you can get a lot of benefit from them. They can actually be lifesavers in certain cases, and they can also cause a lot of harm when they're used improperly. So you use them with respect, but if you need to use them, then they're important to do. But there's a lot, and I talk a lot about it in the book, not just how to choose these medications, but there's certain labs you can do to say, okay, well, this medication is probably going to do a little bit better with me than something else.
So what do you think the best way to do? Should we just get started on the medications? Should we just start with the different
Yeah,
classifications?
let me go through all the medications and then we can talk about each one separately. There's, I don't know, there's probably 10 of them that are osteoporosis specific medications. You have the bisphosphonates. There's 4 bisphosphonates, and that's Fosamax or alendronate. Then there's Residronate, which is Actonel. And then there's Ibandronate, which is Beniva. And there's zoledronic acid or Zolendronate, which is Reclass. That's the infusion. The first 2 I mentioned, the Fosamax and Actonel, they're oral. You take them once a week. Typically, there's different versions, but mostly it's once a week. And the problem with them is that they can give you esophageal issues, GERD issues. And so some people who already have GERD issues, those wouldn't be an option to take it oral. So then it'd be better to have the infusion, the reclass, because you're not then affecting the esophagus. Beniva, I don't ever recommend that because that seems to have the most adverse effects. So I don't really even talk about that. That's called Ibandronate. But the Fosamax and Actonel, they give you probably 1 to 2% of bone density each year. The reclass will give you more. It's much more powerful. It's an infusion. It lasts for about a year, and it gives you 2, 3, possibly even 4% of bone density in 1 year. So, uh, big difference between all of them. And but what's important to know about the bisphosphonates is they do not improve your bone quality. They just improve your bone density. And that's a major issue. Some people have really poor bone density and that they shouldn't be an option. The bisphosphonates are not an option if they have really poor bone density or an option only in limited amounts. But then you have to go to the more potent, more um, bone building or what's called anabolic medications. So the next one of Prolia is the next one, and that is called a rankle inhibitor. It works very, very differently than the bisphosphonates. And, but it also gives you 5%, maybe 4 to 5% of bone density in the first year, and it gives you a teeny bit of bone quality. But there's problems with that drug that we'll get into later. And it can be good, it can be not really bad in certain situations, um, if it's not used properly. And then there's uh, the three major anabolics. The one is Forteo or teriparatide, and um, uh, then there's abaloparatide, which is Timlos, and they're both what's called parathyroid analogs. So they like a parathyroid, um, the parathyroid hormone within they're injectables. So you inject it every day for a year and a half to 2 years, both of them, either the Forte or the Timlos, and they build a lot of bone density, between 8 and 10% of bone density during that 2 years that you're using it. So they're quite good at building actually new bone. And then uh, the last one is Evenity or romosomazole, and that's been out for 2 or 3 years, and it is what's called a sclerostin inhibitor, and we can talk about the mechanism of that later. But it does improve both bone density and bone quality. It acts as a anabolic for the first 8 or 9 months, and then for the last 3 or 4 months, it acts as an anti-resorptive. Then there's also, I didn't mention, there's also the SERMs, like raloxifene, which is a selective estrogen receptor modulator. And I don't typically recommend them either. They do give you a little bit of bone density, maybe 1 or 2, maybe 3%, 2% bone density a year, but they also pretty high risk of thrombosis and issues with um, similar issues with estrogen. And then there's HRT or hormone replacement therapy, which is I recommend a lot, especially for women who don't have terrible bone density, but we want to stop the bone loss. HRT is great for stopping bone loss. So that's kind of all the different options that we have.
Okay, so let's examine these in more detail in terms of the risk factors and who would be a candidate and who wouldn't be a candidate. And because let's just also say we haven't that, what you do is you do an integrative approach. So you use all of the supplements and lifestyle and everything as well. Yes.
I don't necessarily, everybody doesn't need a medication. A lot of people don't need these medications. And just because you have a negative 2.5, just because a T-score of negative 2.5 in your bone density doesn't mean you need a medication of any kind. So everybody's an individual, and everybody has um, different levels of need for a medication or not. And you have to weigh a lot of different things to see what a person's risk factors are. Um, like I said, if somebody has a negative 4.0 and they're at high risk for fracture, just giving them a bisphosphonate, which adds some density, doesn't really, it doesn't do the job really. So a bisphosphonate works by all those four that I mentioned, uh, Fosamax, Actonel, Beniva, Reclass, they all work by essentially killing off the osteoclasts. And I think unless you do proper lab testing to begin with, you don't know if a person has high osteoclastic activity that's causing their bone loss. A person can have what's called low bone turnover osteoporosis, where their osteoclasts are not ramped up. They're not breaking down a lot of bone. The reason why they have low bone density or osteoporosis is because maybe they had all this bone loss earlier in their life, or maybe now their osteoblastic activity is just not capable. So the osteoblasts are the cells that form bone. And as we get older, the mesenchymal stem cells that are the precursors to these osteoblasts, they lose their ability to really form the osteoblast. Now we have less osteoblastic activity, and giving a person a bisphosphonate to kill off the osteoclast actually just decreases osteoblastic activity even more. So a person with low bone turnover osteoporosis is probably not a candidate, in my book anyhow, for, for using a bisphosphonate for them. And
Oh,
we don't know that unless we do lab testing. A lot of doctors don't do the lab test.
wow, and your talk is so incredible on the summit, but basically it's the bone turnover markers to see if you're losing bone. And do you also consider the 24-hour urine in that too?
Consider a lot of them, but a 24-hour urine calcium doesn't necessarily have anything to do with the osteoclast per se. It's more of a function of your kidney ability to resorb that calcium. We always have calcium in the blood going through the kidneys, filtering it out, and then putting it back in. And so sometimes that has nothing to do with the osteoclast per se. But yes, getting 24-hour urine calcium, getting the bone turnover markers, C-telepeptide, uh, uh, what's called P1NP, which is a bone formation marker. Then you do different things, just like a comprehensive metabolic profile, make sure they don't have liver problem, parathyroid issue that might be causing it, a thyroid issue that might be causing it for TSH and thyroid hormones. Um, there's lots of different labs that you really got to look at to decide, number one, if a medication is important, but also what medication. So
This is so important because for many doctors, what they've learned, and I don't fault them because this is the training. This is their training. You have a minus 2.5. First line of defense is the bisphosphonates, and they don't look at the CTX, and they just so many people. And the other thing that I see on a regular basis is someone has maintained maybe 10 years they've had the same bone density, but it's low and they see a new doctor. And they're like, oh, you have to go on medication, bisphosphonates or whatever. That's common. But yet, as if we're going to what you're saying, that it's not an issue with their osteoclast, they're not actively breaking bone down. So this would be really a waste of time and not the proper medication or not the proper treatment at all.
and another very, very unfortunate situation is insurance companies. Sometimes the doctor is kind of locked in by what an insurance company will accrue. And some insurance companies say, hey, we got to do a bisphosphonate first, and what's called an anti-resorptive first. And if that fails, if that doesn't work, then we can do an anabolic, which I talk a lot about in my new book as far as that's not the way to go. You a, an anabolic medication for teotimolose vanity, they don't work as well if you've done a bisphosphonate first, if you've done an anti-resorptive first. So that's another issue that doctors don't have a lot of control over, I think. And it's, it's a situation that's unfortunate. And the doctor and you, the patient, has to fight for, what's best for you and not what's best for the insurance. But if a person's bone density is really poor, they really should be doing an anabolic, not an anti-resorptive first.
So let's go back to the bisphosphonates. Now, in the research, what has been shown in terms of fracture reduction? Because, like you said, the quality of the bone is not improved with bisphosphonates. And that's so, so important. We're just improving the density. But what we're concerned is not the number on the DEXA test. We're concerned about fractures. So,
That
what's been shown in terms of if people are taking this bisphosphonates, their fracture reduction?
right. Who cares what your bone density is? If you got a if you fracture your bone, your bone density was bad enough. So you're right. It's the fracture risk that's the most important. And they do decrease fracture risk. The way they decrease the fracture risk, though, is not by improving density. It's not the density that they improve that causes the less fracture risk. What they do is by decreasing osteoclastic activity, you are lowering the number of what's called BMUs, or basic multicellular units. So every day, a person incurs microfractures, and those microfractures stimulate bone cells to come in, clean out those microfractures with the osteoclast, clean out the microfracture, digs it out. The osteoblasts come in and build new bone. A bisphosphonate, because it kills off, or I shouldn't say it all, it kills them off, but it certainly compromises their ability to function. It decreases the number of BMUs. So you might get a little microfracture, but there's not 10 or 15 osteoclasts that come in and eat out that microfracture because those osteoclasts are sitting over in the corner sick because, it's like a rat poison that just makes them sick. They can't do their job. So there's less and less and less of these BMUs. The more BMUs you have on your bone, and think of like if you looked at my forearm, there'd be thousands, millions of little areas of these BMUs where in the bone, on the surface of the bone and in the bone, where bone is being remodeled. The bone is being fixed, taking these microfractures out. So if you have, let's say, 1,000 in there, it's like stipples on a page of a note page. There's lots of stipples. It's going to be easy to tear out that page. If there's only 100, and that's what bisphosphonates do, they decrease those number of stipples. They decrease those number of BMUs in there. If you fall, it's much less risk of fracturing. So less BMUs, the less fracture risk. And that's the way the bisphosphonates work.
So on the negative side of bisphosphonates, you mentioned people who have any sort of GI issue that it could exacerbate it because that. But the other question is, and people are very afraid of this, and I've seen it happen, and it's scary as can be, the osteonecrosis of the jaw and the atypical femur fracture. So you want to talk about those because they do happen, and
And that's, yes. And that's why at the beginning, it works great because, because it decreases the number of BMUs. But in the long run, after 3, 4, 5 years or more of being on the drugs, then we don't have a lot of BMUs, but we're building up these little microfractures in there. And that makes the bone then more prone to fracture. And that's why we get these atypical femur fractures. That's why we get osteonecrosis of the jaw, because the jaw is very close to the inside of the mouth where we have a lot of bacteria. And because the bone actually gets old in there, it's not able to shed and decrease infection. We get infections in the jaw, and that's where osteonecrosis of the jaw comes in. You're not going to get osteonecrosis of the jaw from being on a bisphosphonate for a year or two. You could get it at 3, 4, 5 years after being on the bisphosphonates. But at the beginning, there's not a huge risk of that at all. And the same with atypical femur fractures. And that's why these bisphosphonates are great to use short term if you have to, because the adverse effects are typically, I have GI issues or I have muscle aches and pains or something like that. But it's not the osteonecrosis of the jaw. It's not the atypical femur fractures. That's just if you've been on for long term.
I've been working with osteoporosis for over 25 years when Fosamax, when they just came out, actually, and they didn't have that 5 year. They didn't know. Just like that's what the problem with new medications. They didn't know that after 5 years, some horrible things were going to happen. And so because they did, that's when they changed the recommendations, which, unfortunately, a lot of people suffered because of that. So the other thing is there are a lot of things that increase osteoclast activity, inflammation, and just different things in the body. And your book talks so much about that, and you do. And so how do you balance which way you would go? Like when you decide, when someone's thinking, should they use this or should they try to reduce, I know you should do everything, but what's your thought on how do you use these medications? Like what would be a person who you think it would benefit in conjunction with everything else?
Well, let's say a person has a negative 4.0 T-score of their spine, and you do bone turnover markers, and they have a 250, 300 for a I use C-telopeptide, the bone formation marker, the bone resorption marker. It's a measure of how much bone collagen is in the blood, and so it's a measure of osteoclastic activity essentially. So it's called a bone turnover marker or a bone resorption marker. If that's really low at 250, 300, 350, then a bisphosphonate's not going to work nearly as well as an anabolic. But if that person has an 800 and they're losing bone rapidly, then a bisphosphonate is going to work a lot better. But if they have a negative 4.0, yeah, we're going to add a little bit of calcium in there. We're going to add a little bit of density in there, but probably a negative 4.0, even if they have a high turnover of 800 CTX, I'd still rather see them on an anabolic because their bone density is so low. But they have a negative 3.0, negative 2.8, negative 3.0. I mean, a lot of those people, if everything else seems okay, I probably wouldn't even recommend a medication. There's no reason for it. You get to negative 3.2, negative 3.3, and there's other things that are going on, and we can't fix them nutritionally right away. Then do a bisphosphonate for a year or two. It buys us time, and that's a great thing that I recommend these medications for, buying us a little bit of time to change their body. The bodies, a lot of the patients I get, they're not doing well in a lot of ways, so we're trying to improve their overall health. And then when their overall health improves, they improve. But in the meantime, maybe we have to borrow some time, buy some time by using a year or two of bisphosphonate.
Okay, so what I understand is if you find out that they're losing bone, that they're increased their osteoclast activity from, from the test that you're doing, the biomarkers, and you like the CTX, but they're not, but it has to be that they're losing, that they're, that they have reduced osteoclast, the increased osteoclast activity, and it's not -4, or it's not, to the extreme where you would use the anabolic, then this could buy time while you're doing all of the other amazing things that both you and I talk about. And do I have that? And
And I do. Let's say a person has a C-telopeptide of a 500, and let me say
well,
also,
tell everybody what normal is so they understand what
uh,
500 means.
that's
Well,
a key question. The normal, when you look at the reference range, it's like, I can't remember, but it's like 100 to 1100, which is crazy. It's a huge, huge reference range. So looking at the reference range for C-telopeptide is kind of worthless. So I've been doing this for many, many years. So I kind of know that around 350, at that, if less than 350, you're not really losing bone typically. Over 350, 375, you're probably losing bone. So even though it's normal, even though it's totally within the reference range, and the problem with CTX is it's not a perfect marker. It is very much influenced by the time of day it's done. That's why it should always be done first thing in the morning. It's influenced by food, so you should always do it fasting. It's influenced by biotin, by collagen. So you have to make sure that you do the test properly, and still it's going to vary 50 to 75 points a lot of times. So they're not perfect, and that's why a lot of doctors don't advocate their use. But if you use them and you really guide that patient on how to prepare for that test properly, then they're very useful. But you use that CTX to your advantage, and you decide, okay, from that and other things, whether we're going to go with this. And a lot of times, like I said, if they're a 500 or so, you might be able to get that down to 350 just by doing alpha lipoic acid and acetylcysteine, berberine, different things nutritionally without using a drug. If they're at 800, 900, I'm not going to get that down to 350 with just nutrition. Probably not going to happen. I mean, maybe if they have, if they're gluten, if they're celiac, if they have dysbiosis, if they have a lot of inflammation, if they have a lot of stuff going on, and you can fix that quickly, you can drop that CTX down. The problem with that is you usually can't drop, you really can't fix a person that quickly. Therefore, you buy some time. You buy time with a year or two of these drugs. Then after that time, we're still fixing them. We're still working on them. And then after 2 years or whatever, you can get off the Fosamax, off the bisphosphonate, and their CTX stays down. That's really cool.
yeah, I think unlike, and we'll go into some other drugs with the Prolia and things like that, but once you get off, then you don't have to go on anything else.
No, yeah.
There's a
I'm
lot to be said about that, as we'll get into,
excited
because
about it.
yeah.
Bisphosphonate great for that. Yes, you can just get on there and get off them. It's nothing, not a big deal. Not that way with Prolia and the others. So,
So when you're testing, when someone let's say someone does choose, they have the certain, they decide that it's going to just take too long. There's too much influence, whatever it is that they want to bide a little time, like you said. And then how often do you test that CTX to determine when they would come off of it?
well, first thing you do is you always, 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 whatever medication you're taking, you always do follow up bone turnover markers 3 months after you start to make sure the drug's working. 5% of the time, the drugs don't work. So I've had patients who they've been prescribed Forteo and the anabolic Forteo, and they didn't do bone turnover markers beforehand or during, and they get to the end of 2 years, they do a new bone density, and they're worse because the drug didn't work. And so all that 2 years, they were getting worse, and they could have prevented that by just doing some lab testing, you know? So, um, so in answer to your question, how often you do it, let's say you're on a bisphosphonate for 2 years. You'd want to do a before medication baseline. Always do that before starting any medication. You should always do bone turnover markers baseline. Then 3 months into it, and then if that says, let's say you start off with a 600 CTX baseline, 3 months into a Fosamax, you get it, and it's 200. It's working. There's not really any major reason then to keep doing CTXs, but at the end, at 2 years, then you'd want to do a CTX to see where it is. And it's probably at that, but because it builds up in your body. So by that time, it might even be 100, 125, something like that. And then after you get off of it, every 6 months, look at that CTX. Where is it going? And it'll stay down like the first 6 months after getting off of it, it's probably still going to be 125. But if it starts building up, and then if it starts getting over that 350, 375 mark, then we might have to go back on it again. Maybe not. You know, a lot of times you reset those osteoclastic activity points. And the reason why is because you've gotten the person healthier in the long run.
I think it's really a good point because I see people in the mindset where, oh, I'm on the medication and that's it. They think that's the panacea, that's the magic pill, that's whatever, or the injection, that they have to do nothing else. And that's so far from the truth. So during that time, as you say, bides time, you're doing everything else. You're getting rid of the inflammation, you're helping your gut and all the other issues. And and so it's just so important for everybody listening that it's not the panacea. It's just like you said, buying time so you can do all the other things. And would you also check, I guess it depends on the person, if they're on it for a year or 2 years, depending on what they need.
Yeah, every situation is different, but while you're on it, as long as it's working, there's no reason to just keep doing CTX and CTX. It costs money, and so I try to make sure that we don't throw people's money away too.
Yeah, because the injection is just once a year. And yeah,
On the reclass, it's
yeah.
a year every year, but reclass is amazing. It can last 2 years. So if you start off with an 800 CTX and 3 months into that reclass, the person gets another CTX and is down to 150. At 1 year, you do another CTX, it's still at 150. Why get the next injection? There's no reason. Do a CTX 6 months later. So that'd be a year and a half after the reclass. Do another CTX. It's still at 150. Why get another infusion? There's no reason. It's down. It's doing its job. Before it was way high, it's down. There's no reason. I've seen it last 2.5 years on people.
And
So,
then, as you said, they can make the other changes as
and there
well. Yeah.
changes that's one of the reasons why it's staying down. But also just the fact that it affects people differently. Like Prolia.
Yeah,
Prolia,
let's talk about this because this I see, and people are not given the information that once you take this, the rest of your life, you may have to be on medication. So why don't you talk about the problems here with Prolia?
Prolia is a huge topic. Um, it, as I said before, it is a rankle inhibitor. So rankle is what's called a receptor activator nuclear factor kappa B. It's a it's a stimulator of a direct stimulator of the osteoclast. So when you decrease rankle, you decrease osteoclastic activity. The problem is it's an antibody against it. And once it wears off at about 6 months, but then uh, it no longer decreases the rankle, and we have increased rankle and increased osteoclastic activity. The problem is with Prolia, well, one of the problems is there's a 210% variability in people's response to Prolia. So some people, it lasts for 5 months, some 6 months, some 7 months, some 8 months, some even 9 months that it works. So the drug companies pick 6 months, which is a good, average. Uh, so that's why they do an injection every 6 months. Prolia, um, it does give you, like I said, 5 to 6% of bone density in a year, and it continues. I shouldn't say. I would say maybe 5 to 6 in 2 years. So
And what about the quality with Prolia?
gives you a little bit of quality, not a lot, but it does add a little bit of quality to the bone. Um, and the interesting thing about Prolia is it does seem to continue to improve, even 3 or 4 years of using it. The problem is the longer you use it, the more difficult it is to get off. So let me explain the what's called the rebound effect. So the rebound effect is when, uh, and it doesn't really happen after one injection. So if you did one Prolia and then switched to an oral bisphosphonate, that would be fine, probably. But if you do 3 injections, so a year and a half or more, you can't just use an oral bisphosphonate. You have to use reclass to prevent this rebound. What happens is when Prolia wears off, the osteoclasts say, "Oh, wow, there's no more rankle inhibitor here." And there's a rankle being produced in the body. They stimulate those osteoclasts, and they burst forward, and they gobble up a lot of bone, and they break down bone. And within a year, typically, if a person's been on Prolia for 2 or 3 years, within a year after stopping it, they're the same as they were before, if not worse, with even a higher risk for fracture than they were before. So typically, if a person's been on for a year and a half or more, they have to do reclass to back it up. A oral bisphosphonate is not strong enough to shut down that rebound effect. And so remember, you got to use the bone turnover marker, the bone resorption marker throughout this to make sure that baseline, see what they are, 3 months into it, make sure it's working. If you decide to get off of it after 2 years, get another CTX, get a reclass. 3 months after that reclass, do another CTX to make sure it works. Sometimes it doesn't work. And then they have to do 2 reclass or something like that. But the rebound is a major issue. And the longer a person is on Prolia, so 5, 6, 7 years on Prolia, sometimes you can't get the person off of it because the rebound is going to be so dramatic that the reclass won't prevent that rebound. And I'll just explain this a little bit. I explain it much more in depth in the book. But the reason why is because as the Prolia affects the osteoclast, unlike a bisphosphonate that essentially kills them off, the Prolia doesn't kill off the osteoclasts. It changes them into these little bitty deflated osteomorphs. And so now you have, as the longer you go on Prolia, you get these islands of osteomorphs floating around in your bone, in your whole system. And you get more and more and more of these clouds, these islands of these coalesced osteomorphs, 10, 15, 20 of these things stuck together. And you get more and more and more. And then you get to 7 years, let's say, and you stop um, the Prolia. These all these osteomosts pump up, they get fatter, they get like these outrageously hungry osteoclasts that just break down the bone and the person's bone density plummets, and then they get high risk for fracture.
Yeah. Is that something that you use,
Aaron,
Prolia?
that's a great question.
Yeah, it's just
Yeah, I do recommend it, because it is a good drug when they use it properly, but you gotta use those bone turnover markers a lot with it, and you gotta really be on top of it, and make sure when you do that transition, the transitions are a little tricky to do, but takes a lot of CTXs, a lot of bone turnover markers to get that transition proper, but it can be done, and, uh, yeah. So I do.
the other thing with Prolia, in terms of infections or, in terms of does it make you more at risk
It does.
for
Yeah.
yeah.
Why is that? And the reason why is because number one, osteoclasts are a form of a white blood cell. And the rankle is, anytime you're messing around with the osteoclast and rankle, you're messing around with your immune system, part of the immune system. So yeah, you are more at risk for especially skin issues and things like that. I haven't had a lot of patients on Prolia. Um, You know, I don't know how many, but I have not had any who've had infections. So,
But if
but
someone's at high risk, if there's issues with
and
if they have autoimmune conditions or other problems, I would think it would be
right, but that's one of the reasons why you when you're figuring this out, which drug to use, then you're looking at things like that. Yeah.
okay. Anything else about Prolia before we move on?
Um, I'm sure there is, but I can't
Yeah,
think.
no, 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 that's good. Just people, and as you say, this is not your first line. You're a person that really deals with you combine them if necessary. You're and that's so important. All right, so let's go now to I guess they're the newest class. It's been around a while, but this has really changed the treatment in terms of the anabolics. So you
Yeah,
wanna
they're fantastic, and because they do. When you look at a bisphosphonate, I always say to people, you got a house and the foundation's crumbling and you run around and you patch up that foundation with some concrete here and some mud there but the foundation is still not really good quality. But when you use an anabolic, you're changing that foundation. You're putting new bricks in there and you're actually forming new trabecular, new parts of that bone. You're eating away, you're taking away the poor bone and you're stimulating the osteoblast to form new bone. So it's a bone quality and density improvement. And it does decrease fracture risk a lot. A little bit of a side to this, if a person has really high loss of bone, so they're negative 4.5, negative 5.0, so a really poor P score, those people are actually at a little bit higher risk for fracture during the first 4 or 5 months of taking an anabolic, like Forteo or Timlos. And the reason why is because they don't just stimulate the osteoblast, they stimulate the osteoclasts also. So, um, so the person is a little bit higher risk for breaking something at the beginning, but within 6, 7, 8 months, their fracture risk does decrease considerably.
and so do you wanna say any differentiation between the 3 that you think is important to share?
Um, you know, Evenity, the sclerostin inhibitor. So let me tell you a little bit about the sclerostin. Sclerostin is produced by it's protein that's produced by the osteocytes. So there's three. I should have actually explained this at the beginning. There's three bone cells essentially: the osteocytes, the osteoclast, and the osteoblast. The osteocytes are essentially they're the governors of bone remodeling. Osteoclast break down bone. The osteoblast build up bone. So the osteocytes, they um, they regulate the amount of activity that's going on, and people don't think of this, but they always think of too little bone, but you can have too much bone too. So there's a condition called osteoporosis, which is, a person who has a +4 bone density, not a -4 bone density. Their bones are really, really, really dense, but they can also be brittle. So you don't want too much bone density. That's not usually a problem with people, but the osteocytes produce sclerostin to do that, to prevent that osteoporosis from happening, to prevent too much bone from being built. And so they produce this thing called sclerostin. And so the rhomosomazole, the Evenity, limits that ability for osteocytes to produce sclerostin. It takes away that inhibition of the osteoblast to do more bone. So now the osteoblast just can produce more bone. And so the way the Evenity works, and it's only a 1-year drug, it's an injection every month for a year. That's all they use it for certain reasons. And at the beginning, like I said earlier, that it acts as an anabolic to build bone, and then it acts as a anti-resorptive. So it's what's called a biphase drug. So it works as an anabolic, then it works as an anti-resorptive. And it does improve bone density quite a lot, more so than the bisphosphonates, more so than the anabolic Forteo or Timlos. So I've recommended it quite a few times. The problem is there's a black box warning on it for heart issues. So a person wouldn't want to have a heart, uh, especially a heart valve issue or any type of heart issue, and take this because there is an increased risk for cardiovascular events from it. Um, the reason why there's an increased risk is because sclerostin is not just produced by the osteocytes, it's produced by chondrocytes. And the cells that form your joints, the cartilage in your joints, the cells that form the cartilage in your heart valves. And so if you're reducing the ability to do sclerostin, to make sclerostin, then that can disrupt heart valve function and give a person higher risk for a cardiovascular event. So, when they did the phase 1, 2, and 3 trials, uh, the risk was higher, but not huge. But they're just being safe and not giving it to people with cardiovascular issues.
And why don't you talk about the black box warning as well for, for Teos and Timlos?
So there used to be black box warning on them because it was interesting because way back, I've been doing this for 20 something years. Um, the, my endocrinologist was one of the major um, players in developing Forteo. And he said, they really pummeled these rats during the investigation with this Forteo, and the rats developed osteosarcomas, so tumors in their bones. And so the FDA made the company put a 2-year black box warning on it to not use it more than 2 years, which is fine because it actually doesn't. These drugs don't work after 2 years anyhow. So your body essentially says, "Hey, I know you're tricking me. I know you're just trying to make me do something I don't want to do here, build new bone." And so it doesn't work after about 18 months to 24 months. But that's the black box warning. But now they found out that it doesn't really. They're not seeing an increased risk of osteosarcoma, so they actually took the warnings off, which doesn't really make any difference because doctors don't use it longer than 2 years anyhow. I actually had a patient, which I could not believe. She was on Forteo for 8 years. I, I was like, I still to this day cannot believe it that for so many reasons. Number one, that the insurance company didn't stop it, that her doctor didn't stop it, that they never looked at her bone density and said, "Hey, you're not improving at all. Why don't we stop it?" But she was on for 8 years. Well,
Wow. So now let's talk about this. So you get off. What happens when you get off
they-
any of these anabolics?
yep, there's a rebound effect also because you're stimulate the parathyroid hormone stimulates not only the osteoblast, but the osteoclast. So the second you stop or the week you stop using Forteo or Timlos, the stimulation of the osteoblasts stops. So we're no longer increasing the bone formation, but the osteoclasts have been ramped up and kind of like a mad hornet's nest, and they continue. That osteoclastic activity continues at a higher rate than it was before, even though the person's off of the Forteo, even though they're not doing the injections anymore. So we have this higher rate, incredibly higher rate of osteoclastic activity going on, and the osteoblastic activity goes down to not much. So now we're breaking down bone within a year or two. If a person doesn't do something to prevent this, then they'll lose all that bone that they lost. So you have to essentially kill off those osteoclasts, and you do that with a bisphosphonate.
Okay, so someone can't just go on 2 years, build my bone, then I'm gonna do all these great natural
Absolutely.
me
Do a
yeah.
bisphosphonate.
Yeah,
Yeah.
so once and I think
It-
that's so important that once I think the mindset, if you're gonna start something, you have to follow it through, otherwise you could be doing really significant damage to your bones. You're causing more harm than good.
And most doctors now know that you have to follow up an antibiotic with a bisphosphonate, but I still, every month, I still get a patient who's coming in. They've been on Forteo or Timlos, and their doctor has stopped and they didn't do a bisphosphonate. And I'm still amazed that that's still happening, but it does,
Now, I
unfortunately.
remember way back being in a meeting, and I don't know if this is still the case. They made a big deal that you would not take Prolia and then Forteo. You would take the anabolics first, and then if you were taking both of those, they were explaining, is that still the case, the order?
Yeah, you should take an antibiotic first because um, when you use an anti-resorptive, I use the word you're sealing off the the surface, but that's not really what happens. But essentially, if you look at it that way, that a bisphosphonate, you're sealing that surface of bone, and now the antibiotic can't get into it. So
Okay.
um, yeah, it will work. There's no doubt about it. It works, but I'm just making this up, but maybe you're going to get 5% of bone density from 2 years on Forteo instead of 10%.
Got
It'll
it.
be less effective.
Oh, good. So tell us, why don't we just before we end, tell us your story, 'cause I love your story, and I think it's so exciting for people to hear what's possible. So why don't you just share a little bit about how you got into this and, how you used the medication in conjunction with everything else?
Well, when I was 45, I mean, I've been an athlete all my life. I was in the Olympic team in 76, um, lots of world championship teams. I did a lot of training throughout my life. And when I got to be 45, I started breaking all of a sudden. So I broke a lot of bones, and I went to 5 endocrinologists, and they all just wanted to give me drugs. And I said, that's not what I want to do. I want to figure out why I have this and fix it naturally. And I just came from a background of, I'm a chiropractor. I don't use drugs, don't use medications. And, you know, but then as I immersed myself in the study of osteoporosis, which I had to do to figure it out, I realized that, yeah, I got to do a drug temporarily to get me out of this hole, because I was in a deep hole. Negative. My first bone density was negative 4.3 for my spine. Next one was negative 4.5. I wasn't going the right direction here, right? So, um, so I did Forteo for 2 years, and then I followed up with Fosamax for 6 months, and it got me out of the hole. And I was breaking a lot, and now I don't break. So
And then
uh,
how did you follow it up? What types of things then did you do?
then I just do nutrition. So lifestyle. I'm gluten free because I'm sensitive. I'm not celiac, but I'm almost. Um, my antibodies go higher. My anti-tissue transglutaminase, anti-gliadin antibodies, they go higher. And even though I'm not celiac, so let me just mention that one topic. I know it's a little bit off topic, but I
No, but
think
that's something I just have to tell you, that's something in this community we've talked about so much because I see it all the time. My husband almost died because he has sensitivity to gluten as well, not celiac, and Yes,
Yeah.
so and I see it all the time with people losing tremendous amount of bone, and once they dial that in, then all of a sudden things improve because they're so yeah, so no, tell us. Yes, this is very, very important.
If a person doesn't need to be off of gluten, then they shouldn't be off of gluten. But if they're sensitive, they should be. And the reason why, and this is so important because most people don't understand it, is celiac disease reduces your bone density because it damages the villi in your intestines. So it decreases your ability to absorb nutrients. But gluten can be detrimental to your bones for another reason. You know, not disrupting the villi in your intestine, but just by stimulating, by activating, by overactivating your immune system, by creating these antibodies, those osteoclasts are a form of a white blood cell. So when you activate your immune system and because you're sensitive to gluten, you're going to stimulate those osteoclasts to break down more bone. So decrease that gluten intake, you decrease those antibodies, you decrease the inflammatory response, the immune response, you're going to calm down those osteoclasts. So that's one of the things I did.
So now tell where you're at now, all the things that you've been able to do.
I do everything. I do Ironman triathlons. I'm doing a marathon this June with my son and the Grandma's Marathon in Duluth, Minnesota. I'll be doing Chattanooga Ironman in September. Uh, Trying to qualify for the Hawaii Ironman World after the year afterwards. So yeah, lots of races.
Yeah, no, well, and it's also really encouraging, and I think both of us believe that so much can be done here, and that's why I love your book, I love the work you're doing. But one other thing, I just so a person that's had a fracture, so if we take 2 people with the same bone density, but someone who's already fractured, do you treat them just a quick question before you do you treat them differently?
Yes,
Yeah.
and the reason why is because bone strength is not bone density. Bone strength is a combination of bone density and bone quality. And so you might have one person has a negative 3.0 and they're going to fracture. Another person has a negative 3.0 and they're not going to fracture. So because, their quality is better. That's why the TBS, that trabecular bone score, is a great tool to have. When I get patients in uh, and they're right on that borderline of me recommending a drug or not, and we get TBS and their bone quality is pretty good, that helps a lot. So bone quality, that's an
Okay,
important
so
part.
a prior fracture, though, that
It,
would that lead you more to then,
that's saying,
utilize the medications?
yeah, because that's saying, hey, I don't care what your bone density is. You just had a fragility fracture, whether it's a negative 3.0 or negative 3.8, you fractured. Your quality probably isn't that good.
Okay. Wow, well, we could talk forever, but this was so great, and you really explained it because it's not simple. It's not simple
Uh,
at all, and it's treated simple. It's treated without the lab testing and everything that you talk about, and also it's not, it's treated like, "Okay, you're done. We did that, maybe exercise, take some calcium, vitamin D, goodbye." And we both know there's so much more involved, and there's so much more that can be done, and the good news is that when it's done properly, look at you. You're running Ironmans. I mean, really, and everything's possible. And that's what I believe, that this diagnosis is a blessing in disguise because you can just make so many positive changes in your life and, really live your life happy and strong and vibrant. And, you know, but
for,
this is,
for me, I agree. It was a blessing in disguise for me. Yeah. And that's why I wrote this new book, because I want people to understand the complexity of it. I want them to be able to go into their MD and say, this is a lot more complex than what you're making this to be. And the book allows people to improve their understanding of not just the the pathogenesis, the why there's bone loss, but the diagnosis, the treatment, everything about it. So
yeah, just bring that book in. But I think knowledge is power. And in today's day and age, we have to inform ourselves. And I just believe that you have to understand as well, not to the extent so that you can figure out who to work with, who you trust. And so, just go on a medication and you're done is not, that's not the way It is, but also not to fear because as you said, in many situations, it really it's just very helpful. So yeah, so thank you so much for being here. So for everybody listening, a couple things. Number one, the book is just amazing. I mean, it's really, I just can't get over how involved it is and how it answers it really every question, but you really go in detail about everything. So it's just an incredible resource. So number one, the book, and you gave how you and I like the title, Great Bones. It's a great title. And so that's number one. Number two, your interview is really Dr. McCormick's interview is so good on the summit. It's all about the different testing and what they mean and how in an inexpensive lab test, your basic blood test that you get, what you can find and what information. So you don't want to miss that. And we'll have the link to sign up for that as well below here. But again, thank you so much. Is there any last minute thing before we end? This has been so helpful.
And just thank you very much for giving me the opportunity to talk about osteoporosis. It's my baby. It's what I truly love to do is help people with their bone loss. And so it's been great, number one, to do the book, but also to have it done and out there. And I'm hoping it does help change some lives for the
Oh,
best.
and one more thing we didn't mention, though, you see people, you actually do consults. So you want to tell people, I mean, that's like a great, great thing that you do. You want to just share the type of work you do that's available to people?
Yeah, whether you live here in Massachusetts or anywhere, I do telephone consults, and I have people mail me all their information, their bone densities, their lab tests. I'll get lab tests, but yeah, I talk them through, how we can get them on the road to better health that way, better bone health and better health overall. So,
And you're also a team player. So you work with whoever people are working with. It's not that they just
yeah,
have to change. Yeah.
no, and I often do 3 people talking on the phone at once. A patient has their MD or their nutritionist or whatever on the phone at the same time. And no, I want patients to have another doctor in their location or another nutritionist or some person that they can go to. I just feel like I can orchestrate how the pieces fit together.
Which is what we need. We need that as we go on our roadmap. We need to figure it out. And once we do, then we're on our journey, clear sailing. So or pretty clear sailing up and down a little bit, but the end result is where we want to be. So thank you. And that's the same, right? They just go to your website. You want
Yeah,
to give that one more time and it'll be in the show notes.
yeah, www.mccormickdc.com.
And I'll have that link as well. Well, thank you again for being here. It's always a pleasure. And I'm so excited that this book is getting out to the world and we're spreading all this information. So thanks so much.
Thanks so much.
Wow, there was so much great information in that interview. And knowledge is power. So it's very important to have the information when you're making your decisions on your treatment. And there's more information in Dr. McCormick's new book, Great Bones, which is truly fantastic. And I highly encourage you to come to the More Natural Approaches to Osteoporosis and Bone Health Summit. Dr. McCormick's talk is excellent on different testing, and he really explains in detail the bone markers, as well as just the tests you can find from your lab results, and really different meanings of some of the tests you may not have even realized. So it's very powerful, as well as all the other things that I put into the summit, and I'm just so excited about. So thank you so much for tuning in, and I look forward to seeing you on the next episode.